Acne vulgaris. Clinical overview. 1. Clinical history. Key components to elicit. Age of onset. Common between ages 12-24, pubertal onset, but also adult onset acne, 25 years. Duration and progression, family history. Genetic predisposition plays a significant role. Menstrual history, in females. To identify hormonal flares. Medication use, for example, corticosteroids, lithium, anti-epileptics, testosterone, skincare products, use of comedogenic cosmetics or occlusive agents, dietary habits, high glycemic index foods and dairy may exacerbate acne, psychosocial impact, quality of life, self-esteem, signs of depression or anxiety, previous treatments and responses, occupational environmental exposure, oils, greases, humidity. 2. Symptoms and pathology. Pathophysiology, 4 key factors. 1. Increased sebum production androgen-driven. 2. Follicular hyperkeratinization, obstruction of the follicular infundibulum. 3. Colonization by Cutibacterium acnes, C. acnes. Anaerobic gram-positive bacterium. 4. Inflammation triggered by C. acnes and keratinocyte activity. Symptoms: non-inflammatory lesions, open comedones, blackheads, closed comedones, whiteheads. Inflammatory lesions: papules, pustules, nodules, cysts. Pain, tenderness, in moderate to severe inflammatory acne, scarring or post-inflammatory hyperpigmentation, PIH, especially in darker skin types. 3. Signs and clinical investigations. Clinical examination, distribution, face, especially T-zone, chest, back, shoulders. Lesion types, quantify inflammatory versus non-inflammatory lesions. Severity classification per American Academy Dermatology, AAD. Mild, mainly comedonal, few papules, pustules. Moderate, more widespread, notable inflammation. Severe, numerous inflammatory lesions, nodules, cysts, scarring. Investigations, selective use, hormonal evaluation in females. Consider if signs of hyperandrogenism, for example, hirsutism, irregular menses. Tests, serum total and free testosterone, DHEAS*, LH, FSH ratio. Culture, if atypical lesions or resistance suspected. Wood lamp, occasionally used to highlight C. acnes colonization, orange-red fluorescence. Asterisk dehydroepiandrosterone sulfate, a sulfated steroid hormone that serves as a precursor to androgens, like testosterone, and estrogens. 4. Complications: physical, scarring, ice pick, rolling, boxcar, hypertrophic, and keloid scars. PIH, common in Fitzpatrick skin types, Ivor 6. Persistent acne into adulthood, psychosocial, depression, anxiety, social withdrawal. Strong association with reduced self-esteem and quality of life. Asterisk. The Fitzpatrick skin type scale classifies skin by its reaction to sun exposure. Type 1, very fair, always burns. Type 2, fair, burns easily. Type 3, medium, sometimes burns. Type 4, olive, rarely burns. Type V, brown, very rarely burns. Type 6, dark brown, never burns. Types I4, 6 have more active melanocytes and more baseline melanin in the skin. When inflammation occurs, for example from acne, melanocytes respond more aggressively, producing excess melanin at the site of inflammation, hyperpigmentation. As a result, acne lesions in darker skin types are more likely to leave lasting dark marks, even after the acne is gone. 5. Therapies based on severity and lesion types. Follow AAD, EDF, and Global Alliance guidelines. Topical therapies. First line for mild to moderate acne. 1. Benzoyl peroxide, BPO. Bactericidal against C. acnes, reduces resistance risk. 2. Topical retinoids, adapalene, tretinoin, tazarotene. Normalize keratinization, comedolatic, and anti-inflammatory. 3. Topical antibiotics, clindamycin, erythromycin. Always combined with BPO to prevent resistance. 4. Azelaic acid anti-inflammatory, helpful for PIH and rosacea overlap. Combination therapy, for example retinoid plus BPO or BPO plus antibiotic, is more effective than monotherapy. Systemic therapies for moderate to severe or resistant acne. 1. Oral antibiotics, used for 3-4 months to limit resistance. Preferred, doxycycline, minocycline. Alternative, sarecycline, narrow spectrum, FDA approved. Not first line, erythromycin, high resistance. TMP SMX, reserved. 2. Hormonal therapy, females only. Combined oral contraceptives, COCs. FDA-approved types contain ethinyl estradiol plus anti-androgenic progestins, for example, drospirenone. Spironolactone, androgen receptor blocker, effective for adult female acne. 3. Oral isotretinoin, for severe nodulocytic acne or refractory moderate acne, reduces sebum, normalizes follicular keratinization, anti-inflammatory. iPledge Program, USA. Strict teratogenicity precautions. Dosing, typically 0.51 mg/kg/day to cumulative dose of 120-150 milligrams per kilogram. Requires monitoring. Liver function tests, lipids, pregnancy tests, females. Adjunctive and maintenance therapy maintenance. Topical retinoids, plus BPO. Light laser therapy, limited, variable efficacy, not first line. Chemical peels, for example, salicylic acid, glycolic acid, useful for comedonal acne and PIH. Lifestyle and diet: low glycemic index diet. Some evidence suggests benefit. Limit dairy, especially skim milk. May aggravate acne in some. No evidence supports avoiding chocolate or fatty foods universally. Do not use topical or oral antibiotics as monotherapy. Long-term antibiotics, 12 weeks without reassessment. Aggressive skin scrubbing or harsh cleansers can worsen inflammation. Summary table: therapeutic approach by severity. Mild, topical retinoid, plus BPO, plus azelaic acid. Moderate, topical retinoid plus BPO plus oral antibiotic. Severe, oral isotretinoin or oral antibiotic plus topical retinoid plus benzoyl peroxide. Female hormonal acne. Add combined oral contraceptives with or without spironolactone.